I'm Dr. Urmil Shah, cardiologist at practicing past 20 years. I'm the director of the CIMS hospital, which is hospital, Ahmedabad. Since you look at myself, before 20 years when I started in practice, and right now, you can see a big difference in patients who are coming with uh, a heart failure. Okay. Now, you all will agree with me that more and more number of patients are coming with heart failure diagnosis. And primarily because they have survived the matter of heart failure, which is one of the reasons why they are now coming with a heart failure. Second thing is, a patient with diabetes symptoms also are coming with heart failure, not more failure of this one, mainly because of the survivor, diabetes, all these things. Right now, what we'll be talking is mainly about the heart failure with reduced infection, not with the hospitalization. We have two topics today. One is regarding the diagnosis, especially the biomarker. It's very useful diagnosis to investigate how to target the our patients. So this is the first one. The second topic will be the disease in patients with influence heart failure. So you all know that there are so many new molecules like say RNA or I said inhibitors are available right now with us. So how to use it, when to use it, is important aspect that we are discussing about. And another important thing is when to use the device that we and to get the heart transplant because we know that heart transplant management, heart failure management is primarily a team, not by the individual person. And at CIMS hospital, we have a very big heart failure team. So definitely we can have a better uh, treatment for a patient because in a single center we have all the options of heart failure starting from medical management to the heart transplant. So over to you. I will be going with the video of my lecture.
Intermax score is very helpful to find out if it is PVR, a patient is and I doesn't have any financial disclosure related to this topic. When there is a cardiac condition which leads to a myocardial necrosis, it causes an elevation of troponin. When there is a hemodynamic impact, it causes an elevation of BNP. And when there is an inflammation, it can cause an elevation of HSCRP. If you know about this marker and if you use them judiciously, we can optimize the management in most of the patients. Whenever there is a wall stretch, it can lead to elevation of pro-BNP. It will divide into equal portion, 1-to-1 ratio to anti-pro-BNP and a BNP. Anti-pro-BNP is an inactive molecule, whereas BNP is an active molecule with a half-life of 20 minutes. And we know that BNP is beneficial. BNP is normally degraded into inactive component by neprilysin. Guideline clearly mentioned that BNP should be used to support the diagnosis and as well as exclusion of the heart failure, and it is both used in acute and chronic condition of heart failure. Whenever there is a suspicion of heart failure on a clinical ground, and if anti-pro-BNP is less than say 125 or BNP is less than 25, we can exclude the diagnosis of heart failure. At the same time, in acute condition also, if BNP and anti-pro-BNP is low, we can exclude the diagnosis. And if it is high, we can include them in the heart failure diagnosis. If you use the BNP in emergency room, it definitely reduces the cost, it reduces the time for diagnosis, as well as treatment is started fast, so mortality also can be reduced. If you do a serial monitoring of BNP, if it is persistently elevated, then the prognosis is not good. At the same time, if it is elevated to start with and comes down, that means prognosis is good in this group of patients. Whenever there is an acute dyspnea patient or a patient who has exacerbation of symptom, BNP is very useful as diagnosis is concerned. At the same time, it is very useful for as far as prognosis is concerned in NYHA class 2 to 4 patient, at the same time in all hospitalized patients. BNP is also useful for a pre-discharge level prognostic value. BNP is elevated because of so many conditions: heart failure, acute coronary syndrome, pulmonary embolism, congenital heart disease, arrhythmias, pulmonary hypertension, as well as non-cardiac condition like subarachnoid hemorrhage, renal function, liver dysfunction. Suppose there's a patient, 56 old, he is known patient of COPD, hypertension. His ejection fraction is normal. Last 3 days of worsening of symptom as far as breath is concerned. We don't know the diagnosis on clinical examination. Patient is having mild basal crabs, otherwise everything is normal. And if you do an anti-proBNP in this patient, and if it is elevated, like in this patient, it is 1272, it is definitely because of heart failure. Okay. Suppose the anti-proBNP comes to like 75, then practically we can rule out the heart failure. Another patient is there who has undergone angioplasty before 7 years. Patient is on reasonable stable medication like diuretic, beta blocker, enalapril. Ejection fraction is 32%. His anti-proBNP is 1525. So definitely it is a high anti-proBNP. Patient is having NYHA class 2. So we can say that low ejection fraction, clinically patient is symptom free, but definitely anti-proBNP high. That means the disease is not very well controlled. And we need to optimize the therapy in this patient by adding either mineralocorticoid antagonist or switching to from ACE inhibitor to ARNI. So if you guide the therapy with anti-proBNP, it can reduce the mortality, heart failure readmission. Pre-discharge anti-proBNP also is very helpful as far as prognosis is concerned. And we can motivate the patient. We can tell that last time the anti-proBNP was high, you have taken treatment, now it is going down, and we have to keep it on the lower side. Other than that, cardiac condition, pulmonary embolism whenever is there, hemodynamically stable patient, anti-BMP is a prognostic marker also. In acute coronary syndrome also, anti-proBNP is an important prognostic marker. And nowadays, recently, a pre-op assessment for a non-cardiac surgery also, anti-proBNP has been found to be useful to prognosticate the patient. So in summary, as far as anti-proBNP is concerned, acute heart failure, decompensated setting, when the cause of dyspnea is not clear, anti-proBNP is very helpful. At the same time, it also improves risk stratification. Obesity, renal dysfunction, atrial fibrillation can alter the anti-proBNP level, and you can titrate the therapy or guide the therapy with the help of anti-proBNP. Troponin also is a very important marker. We all know that it is because of myocardial injury. Myocardial injury can occur with or without ischemia. Myocardial injury occurring without ischemia also has a prognostic importance. Suppose the myocardial injury is not there, then definitely troponin level is going to be less than 99 percentile or maybe undetectable. If it is more, that means patient is having some sort of a myocardial injury. It could be because of non-ischemic conditions like anemia, hypoxemia, shock, kidney disease, ventricular arrhythmia, heart failure. At the same time, if there is an ECG evidence or symptom evidence of ischemia, then definitely it is suggestive of a myocardial infarction. So we know that there are so many causes of troponin elevation. Acute MI, we know unstable angina, spasm, post-angioplasty, non-ischemic conditions also are there like viral myocarditis, pericarditis. At the same time, non-cardiac conditions like renal failure, subarachnoid hemorrhage also can cause a troponin elevation. It's important that whenever there is an acute myocardial infarction or acute injury, there is always a rise and fall in the troponin level. Okay, and it can differentiate it from the chronic causes of troponin elevation. So if there is a significant fall or a rise, it's suggestive of a cardiac acute condition. So suppose the troponin level is high, more than 99 percentile, it is called as a stable when the difference in the follow-up troponin level is less than 20%. And there are conditions like structural heart disease or a chronic kidney disease where troponin can be chronically elevated. If troponin rise and fall is there, that means it's an acute ischemia. If it is without ischemia, then it is primarily because of the acute heart failure or myocarditis. If it is associated with ischemia, then it is either a type 1 myocardial infarction or a type 2 myocardial infarction. Compared to the conventional troponin, standard troponin level, high sensitive troponin level is very useful in early diagnosis because in the early hours, 1 or 2 hours, 3 hours, the HS troponin level rises much faster compared to the standard conventional assay. And the advantage of this is we can have a good emergency discharge if the troponin, HS troponin has been used. We can safely exclude the diagnosis of acute coronary syndrome. At the same time, if diagnosis fit or fast, then we can start the treatment also fast, and that is very useful to reduce the mortality and morbidity in this group of patients. Suppose there is a possible ischemic presentation in the emergency room and you get an ST elevation, then practically we can say no need of a troponin level. But if ST elevation is absent, then we have to get this troponin level and we can repeat it after 2 hours. Suppose the first level is very high, say more than say 5 times the standard level, then definitely there is a very high chance of myocardial infarction. We have to start the treatment immediately. If it is less, okay, and after 2 hours, if you get it again, And if it is coming on the lower side, then definitely we can say that you can exclude the patient and we can safely discharge the patient. If troponin level is high and you repeat it and there is a variation in the troponin level, it is either because of acute myocardial infarction or it is because of acute myocardial injury. So SS troponin level is very useful in emergency room as far as diagnosis is concerned. Suppose this is a patient, 46-year-old patient who is having anterior chest pain, comes in the emergency room, elevated lipid is there, borderline sugar is there, hypertension is there. Last 1 or 2 hours, patient is having a chest pain. Physical examination is by and large normal. ECG also does not show any significant ECG changes. Troponin, creatinine is normal, and initial troponin at the time of admission is 36, so definitely is more than the normal value. And you repeat it after 3 hours, it is going down, so it is like 20. That means there is a acute injury or acute ischemia which is occurring, and this patient had a typical angina. HS troponin level drop from 36, so that's a significant drop. So diagnosis MI is concerned, and we have to, when we did the angiography, there was a tight LED block and angioplasty was done. There's another patient, 47-year-old, he's having chest pain, shortness of breath, pedal edema. Patient is long-standing diabetes, he has altered renal function since long. On the admission, saturation was low, X-ray was showing a little bit of pulmonary congestion. Creatinine was very high because patient is having CRF. His HS troponin level is 32. And we don't know, this is also a very high troponin level. Patient is having diagnosis of renal failure with volume overload, dialysis required. We repeat the troponin and troponin repeat was 31. So there is no significant drop or rise in the troponin level. So we can rule out the acute condition. Patient was discharged after dialysis very safely, excluding the diagnosis of myocardial infarction. I'm going to talk about the patient with advanced heart failure. I do not have any disclosure related to this talk. Defining advanced heart failure is very important. It basically means a severe persistent symptoms of NYHA class 3 and 4. Severe LV dysfunction, ejection fraction may be in the range of about 10 to 20%. Patient requiring recurrent pulmonary, admission because of recurrent pulmonary congestion or low output state requiring inotropic support or a ventricular arrhythmia and unplanned admission more than one in last 1 year. Severe exercise tolerance, additional criteria related to pulmonary lung damage or a kidney damage, and NYHA class 3 or 4 with an excess capacity which is low, which can be measured either by a VO2 max, which is a very, very simple test. It is something like a treadmill test. If the VO2 max is less than 14, then definitely it defines that patient is having advanced heart failure. If it is a more than 18, it is basically a cardiorespiratory test. If it is more, definitely we can say it's a basically objective evidence of finding out exercise intolerance. And another important thing is 6-minute walk distance. If it is a less than 300 meter, that means patient is definitely having an advanced heart failure. Now, whenever there is advanced heart failure on the clinical ground or with excess capacity, then one has to refer the patient earlier to the tertiary center. And what can be done is one can optimize the medicine. One can always give an option of a device therapy or a catheter-based intervention or consider for the heart transplant. Whenever we are giving NYHA class 3, when patient is having advanced heart failure, diuretic is an important part of the treatment. Diuretic, sometimes patient is having a diuretic resistance, failure to decongest despite of escalating dose, and often associated with worsening of renal failure. In this situation, addition of other diuretic in the form of loop diuretic will be very helpful. There are 3 other diuretic which is available, that is metalozan, chlorothalidine, and tolvaptan. All these 3 in addition to loop diuretic is going to be beneficial. Tolvaptan has advantage, it does not cause less of the hyponatremia. MRA use has been found as it is class 1 indication, but it is underused. It is known that about 30 to 40, 50% of the patients are not taking MRA because of the fear of patient may develop in hyperkalemia. 20% of the patients do develop this thing, and that is then they cannot take it. Gynecomastia sometimes develop. If it is there, then definitely it can be switched over to eplerenone and compared to the spironolactone. And if it is because of hyperkalemia, we can give a molecule which is available in USA, where it is a potassium binder, and it can reduce the potassium, and one can take the MRA which is a class 1 indication this for patient. Whenever there is a patient who is having heart failure, we have to optimize the therapy in the form of ACE inhibitor ARB. We should know that enalapril optimum dose is 20 milligram BD. If it is lisinopril, it is 40 milligram daily, and it is enalapril, it is 10 milligram daily. Similarly, valsartan is 160 milligram twice BD. Spironolactone and eplerenone, the dose is maximum 50 milligram. Suppose the patient is still symptomatic, then definitely option is switch over to ARNI from the ACE inhibitor, ACE inhibitor. Second is, if there is a wide QRS, definitely there is an option, and always follow the heart rate. Whenever we are using ARNI, sometimes there is a fear of hypertension. We have to start with a low dose, especially if the patient is having liver or a renal dysfunction, and if patient is not taking any ACE inhibitor or ARB previously. It gives advantage in the form of 30-day reduction in the heart readmission, and mortality also should be used whenever the patient is admitted. It should be started immediately after the patient has been stabilized. Heart rate is important, especially if it's a sinus rhythm. If patient is on tolerating the maximum dose of beta blocker and still heart rate, resting heart is more than 70, we have to think of adding ivabradine in this subgroup of patient. If the patient is in atrial fibrillation, ivabradine has practically no role. When the wide QRS is there, we have to think of CRT or CRT-D or CRT-B. Both are very helpful to improve the long-term outcome. CRT class 1 indication, whenever there is a LVB configuration, ECG and QRS duration more than 150, it is class 1 indication. If it is LVB morphology, QRS duration between 120 to 150, it is class 1B indication. And if it is RBB morphology in a very wide QRS, it is a class 2 indication. But by and large, whenever there is LVB, we have to consider a CRT therapy in this group of patients. Do not forget the comorbid condition. It may be in the form of diabetes, maybe in the form of iron deficiency anemia. If the patient is having coronary disease, ischemia, first and foremost thing is to correct this thing. And if patient has sleep apnea, it also should be taken care. Iron deficiency is very important. We have to treat in most of our patients, but especially important thing is to measure a T-stat, that is a transferrin saturation. If the transferrin saturation is less than 20%, it is an ideal candidate of giving an IV iron therapy. SGLT2 inhibitor, we all know it is beneficial both as far as heart failure is concerned and as far as renal outcome is concerned. So it's a class 1 indication. Any patient who is having LV dysfunction should be either on metformin, that is a cardiovascular safe molecule, and second one is a SGLT2 inhibitor, either empagliflozin, canagliflozin, or dapagliflozin. Hydrolyzin combination sorbitate is a very useful additional therapy if the patient is not getting control with an ARB and ACE inhibitor, or if patient is not tolerating because of some or the other reason, it can be started. Digoxin is class 2B indication, not a class 2A indication. Always refer the patient early to the tertiary center or timely to the tertiary center, which is very important. This is the patient, 72-year-old. He is a known case of diabetes, HbA1c of the higher side. Before 3 months only, he had worsening of heart failure symptom for which he requires an admission. Patient has a reduced exercise capacity in between 2 admission. 6-minute walk distance was only 200 meters. ECG is a wide QRS, LV morphology, 140 millisecond. Ejection fraction is only 20%. Blood pressure is relatively preserved. Hemoglobin is low. His NT-proBNP is high. Patient was on maximum dose of ACE inhibitor, beta blocker, and diuretics. So definitely, this is a classic patient of an advanced heart failure. What are the options for this patient? Definitely MRA, which is a class 1 indication, should be added to this patient. Replacement for ACE inhibitor should be replaced with ARNI, and ivabradine also should be given because patient was on maximum dose of beta blocker. Still, the heart rate, resting heart rate was about 90. Diabetes is there. Definitely, we have to switch over to the SGLT2 inhibitor, and IVI therapy is very useful after measuring the T-stat saturation. And later on, the option for the patient is either CRT-D therapy or a CRT-B therapy. Whenever discharging the patient, make sure that patient is reasonably stabilized. We can take the help of NT-proBNP. If it is high, that means the program is not good, or we still requires an addition of some monitor. Adjusting the therapy. Electrolyte is important, even with the heart rate at the time of discharge. Heart failure readmission is a very big problem. If there's a recurrence of heart failure admission, that means patient is going to worsen in the near time. Another option to prevent the heart failure readmission, one important thing is to monitor a PA pressure. If you are monitoring, there are certain devices which are available. US FDA has approved this. And primary purpose of doing this thing is to measure the pulmonary artery wedge pressure and cardiovascular impedance, which can help to reduce the readmission. Whenever the patient is having advanced heart failure, as I have told that QRS is say more than 120 therapy, then the CRT will be required. NYHA class 3, 4, 6 minute walk distance is 300 meters. Peak VO2 max is less than 40, which is a classic criteria for diagnosing, and frequent hospital admission. Definitely one has to think of heart transplant and LVAD. If the patient is eligible for heart transplant, then there is the option if the donor is available. If donor is not available, then we can put an LVAD till the donor waiting for the heart transplant. There are certain group of patients which is not eligible, like high PVR. A patient is having renal insufficiency or hepatic insufficiency. We have to consider LVAD in this group of patient. Intermax score is very helpful to find out. If it is very low, that means 1 or 2, that means patient is not going to benefit from LVAD therapy. So logically, when the patient is having frequent admission or patient is stable but not having a good exercise habit, that is a good time to refer for the this thing. Our patient which was there, which we had treated, optimized the therapy, was stable for about 4 years, and then patient has a deterioration. He required a recurrent admission. Diuretic was required, and anthropic support was required. Patient was already on the CRT therapy. Patient was referred for the heart transplant, but at that time there was irreversible kidney dysfunction or severe irreversible pulmonary hypertension, and the Intermax score at that time was only 2, as the patient was having multi-organ failure. So this is the patient where now a heart transplant or a LVAD also cannot be useful. So the message is you have to transfer, you have to refer the patient for a tertiary center timely, so that LVAD therapy or heart transplant may be an option for this group patient. So initially it is a medical therapy, then comes a device therapy. There are so many options there, and later on, ultimately, it's going to be either LVAD or heart transplant. But timely reference to the tertiary center is very important if you want to give benefit to the patient of advanced heart failure. Thank you very much.
So, good evening, everyone. Again, there are certain questions which are there. I'm going to address them. One first question is: are there is any shortcoming of BNP or cardiac troponin as a biomarker? Now, we all have to understand that whenever we are recommending to get either troponin or say anti-pro-BNP, we are advising to the patient, we should be very well aware that why we are recommending that. We have to have a little in-depth idea about that biomarker, as this was discussed in the lecture itself. Now, suppose if it's a BNP, we all know that it's a very useful marker. It's a class 1 indication when we want to either stamp the person as a heart failure or to rule out the person as a heart failure. That is class 1 indication. At the same time, it is very important for the prognosis also. So it is a very, very, very useful marker. And but at the same time, if we are looking at the shortcomings of this marker, then definitely we can say that there are certain false positive. Okay, so it is not necessary that all the patients with heart failure will have elevated NT-proBNP. There are so many other causes. Okay, suppose the patient is having say renal dysfunction, patient is having say atrial fibrillation, patient is say having pulmonary embolism, patient is having pulmonary hypertension. These are all the other causes where also NT-proBNP is elevated. So that thing we have to keep in mind when we are getting some this test done and we are interpreting that result. Okay, so in a patient who is having renal dysfunction, atrial fibrillation, it may not be of great help to get BNP, or we should be aware that it may be on the slightly higher side. There are different range also for the patient who is having atrial fibrillation or renal dysfunction. So that important thing we have to keep in mind. Regarding the troponin marker, I would say that timing is very important. Onset of chest pain or the onset of event is very important. Suppose the time duration is very less, okay, and that is a reason in the lecture also I have recommended that many times we have to repeat the troponin, especially HS troponin. Now, when we are talking of the troponin level, we have to make sure that it is HS troponin, or what we can call as a high sensitivity troponin, which is very useful nowadays. It is available. We are using that thing only. Primary advantage of this is it can detect a very low amount. That is one thing. And second thing, it rises in the blood quite early compared to the regular troponin. So if the patient has onset of chest pain, say 2 hours, then definitely HS troponin is going to be of great value compared to a standard troponin. If say it is 8-10 hours duration, then maybe regular troponin may be okay. But if you are doing it, that is one important thing. Here also, if you are going for troponin as a biomarker, we have to understand there are so many reasons for elevation of troponin. It is not only cardiac, okay, but when it is chest pain and a troponin which is high, okay, significant high, as I have mentioned, that it is say 5 times more than the normal range, then definitely we can clearly diagnose that patient is having acute myocardial infarction, or patient will require an urgent coronary angiography. If it is slightly high, not more than 5 times higher than the troponin level, then there are so many other things also we have to see. And one important message I wanted to give is whether this cardiac condition, what problem is occurring inside the heart, is acute or it is chronic. That can be differentiated primarily by repeating the troponin. Okay, and if on repeating the troponin, if the level of troponin has say increased to say about more than 20%, or it has decreased to more than 20%, that means whatever has happened inside the heart, or whatever is acute event which has occurred, it causes a dynamic. That means the blood level is going to vary with time duration. And if it is remaining static, that means whatever is there, it is something because of the chronic condition. It is not of an acute condition. So our purpose in this situation, whether patient is having some acute cardiac problem or acute ischemia is there or not, where HS troponin also is very helpful, and repetition of HS troponin also is very helpful, because if there is rise or fall in the troponin level, as I have mentioned in one of the case, that it is very good, and we can start the treatment immediately. We can give an antiplatelet agent, we can start the intervention, or angiography can be done if there is rise and fall in the troponin. At the same time, one of the case it was mentioned that troponin is very high in a CRF patient. Okay, so a CRF patient comes with the chest pain, and we are getting this troponin. We know that it's going to be on the higher side, but at the same time, if you repeat it, say after 4 hours or 6 hours, if there is rise or fall, that means some acute cardiac event also has occurred in a patient who is having pre-existing renal dysfunction. So that also where rise and fall is very important. If it is not there, then practically it may be because of CRF itself, and we can discharge the patient, or it is mainly dialysis or other treatment is required, which I have mentioned in the case. But if there is rise and fall, that means from coronary point of view, we have to look into it and we have to find. So these are some of the limitations of what we can say NT-proBNP, or what we can say a troponin. So when we are using, time duration for troponin is important. At the same time, false elevation of troponin as a biomarker, or false elevation, or not, I will say false, but because of some other condition other than say heart failure for NT-proBNP, or for say acute coronary syndrome for troponin. If you are aware, then we can it's going to be really helpful in our day-to-day practice. Another question which has been asked is mild congestive heart failure, when it is tricky to recognize whether it is because of lung or liver or say kidney disease, which is many times mimicking the congestive heart failure. Which investigation is preferable? It is 2D echo or BNP? Now this is a very important question. Okay. Now as I have told, this is a very common scenario that patient may be having say smoking, or maybe having mild COPD, and patient comes with a little bit of exacerbation of symptom. And at that time, we are not aware, or it's very many times very difficult to diagnose whether it is because of the exacerbation of heart failure, or it is because of lung problem, or maybe some respiratory infection which has caused worsening of the symptom. This situation, definitely NT-proBNP is very helpful, because we know that in a lung condition, it's not going to be there that NT-proBNP will be high. Okay, so primarily if a patient like this comes to me, and if I may not do echo, because echo also is useful. I will just discuss that thing later on. But primarily, if you look at it, it is going to be NT-proBNP. And if NT-proBNP is say normal, say less than 125, practically straight away I can tell the patient that whatever symptom exacerbation is that it is not because of cardiac condition. There is no need to adjust the cardiac medicine straight away. You can go to a pulmonologist, or what I will do is give some treatment for as far as lung is concerned. Another very important thing is a question which has been asked is whether 2D is first or a BNP is first. I would say BNP has little gain more importance because of its advantage of both ruling out and at the same time rule in. Okay, so this way definitely it is much more helpful. What I would say why NT-proBNP is should be done early, because many a times we can have a patient who is having heart failure with preserved ejection fraction. That means on echocardiography ejection fraction maybe is a 60%, but it may be a diastolic dysfunction which is causing a problem as far as is the symptom person is concerned. Now, if this is a scenario, so suppose patient comes, he is having say long-standing hypertension or diabetes or maybe having coronary disease, and if you do an echocardiography and you find that echo is say ejection fraction 60%, that means many a times we get a false sense of assurance that if ejection fraction is 60%, patient is not going to have heart failure, or whatever symptoms of breathlessness is there, it may be because of something else. Now, if this time, if we have done a NT-proBNP or a BNP, and if it is high, then we can straight away stamp this as a diagnosis of heart failure with preserved ejection fraction. Now, this is the disadvantage of doing echo earlier than NT-proBNP, because NT-proBNP can pick up both patient with heart failure with reduced ejection fraction as well as with the preserved ejection fraction, whereas echo will find out only patient with LV dysfunction. It of course it can have a certain diagnostic criteria for diastolic dysfunction also, like reduced LV compliance or that is what we call E dash prime. These are left atrial dimension, but primarily it may not be very specific. So definitely it's going to be a very useful thing to do a NT-proBNP or a BNP as a marker. As I was told, both in condition with acute heart failure, patient comes to the emergency room with acute breathlessness, or patient is a known case of heart failure and there is a symptom worsen. At that time, this is going to be, of course, we cannot say that echo is not useful, but definitely NT-proBNP should be used much more frequently, according to me and according to the latest guideline, because it is very helpful in ruling in as heart failure patient and ruling out of the heart failure patient. So that is a very important thing we have to keep in mind. Another question which has been asked is, does a multi-marker methodology for the same diagnosis purpose increase the accuracy or create a confusion? Okay, like troponin or CKMB. As I was told in the beginning, when we are using biomarker, we should have an in-depth idea about this biomarker. Okay, then we can have a clear idea. If we are not having a detailed idea about the troponin, where it is elevated, what is the time duration, what is prognostical importance, what are the other conditions which is going to cause a high troponin elevation. At the same time, say for CPKMB, what is the time duration? If this thing is not known, then you may get confused, or ultimately you may not reach to the proper diagnosis. So if we have to have a similar thing is for the NT-proBNP and the BNP. So if you are not aware that atrial fibrillation can cause NT-proBNP on the higher side, if you are not aware that a kidney dysfunction can cause NT-proBNP on the higher side, now this thing, if you are not knowing, then it may create confusion. Another important thing is, many a time there are certain conditions which can cause elevation of NT-proBNP also, in conditions which can cause a troponin elevation. Like suppose there is acute myocardial infarction and patient is having say LV dysfunction. Patient has come to you with the breathlessness, with some ECG changes, and at that time, if you are getting an NT-proBNP and if it is high, okay, then sometimes and if you're not knowing that acute coronary syndrome also can cause a rise in NT-proBNP, then sometimes may get more confused. Okay, so at that time, it may lead you may think in terms of say heart failure and may not take care of the acute coronary syndrome, which is many times not a good thing. So that thing also you have to keep in mind. At the same time, suppose there is a pulmonary embolism is there. Okay, now pulmonary embolism also can cause an elevation of troponin as well as elevation of NT-proBNP. So if you are not aware of this thing, and you are just simply thinking that NT-proBNP is high, so now it is heart failure, so you may be misled about this. So many a times when we are having a multiple marker methodology, when we are using troponin, when we are using NT-proBNP, at that time we have to have a very clear idea about exactly what is causing the problem, and we have to conceptually knowing that like NT-proBNP is elevated primarily whenever there is a wall stretch. Okay, now if there is a wall stretch because of say pulmonary embolism, right ventricular wall is stretched, or say pulmonary hypertension is there, which is causing right ventricular wall stretch, then also NT-proBNP is going to be high. Similarly, as far as troponin is concerned, that also you should be aware that timing is important, the rise and fall is important, and there are so many other causes which can cause troponin elevation. It may be like pulmonary embolism, or it may be like atrial fibrillation, or maybe a renal dysfunction. So this in-depth idea should be there when we are relying on troponin or say BNP as a marker. Another question which has been asked is, which is the best drug for the treatment of heart failure? Now, this is a very broad question. I would just like to answer that for heart failure treatment or management, medical management, we have to be knowing that there are so many practically causes of so many newer molecules which are now available. So I would say that is a very nice slide. I have not shown in this, but there are 5 pillars which are very important for heart failure treatment is concerned. So one of the important pillars is beta blocker. Second important pillar is ACE inhibitor or say ARNI. That is second thing. Third important pillar is MRA. That is an aldosterone receptor antagonist. Fourth very important thing is primarily the SGLT2 inhibitor. And another important thing is the ivabradine. So these are the five pillars where it should be used. So what has been found is all these things should be there, okay, unless it is contraindicated or patient is not tolerating. Another important concept is when we are giving this molecule, definitely it's going to be something like you have to optimize, you have to go to the highest possible dose level which patient is tolerating, because many times I have seen that many of our patients are taking say beta blocker, ACE inhibitor, but in a very low dose, okay, they are not up titrated where it should be. So the overall concept you have to keep in mind that whenever we are using this molecule, they are important molecule, they are class 1 indication. At the same time, dosing is also very important. Okay, so optimum dosing should be there. Beta blocker in a very small dose is not going to serve the purpose. We have to keep this in more and more amount, maximum dose which patient is tolerating. The similar thing is true for the ARNI. I'm a very great fond of ARNI. I have many of my patients on ARNI nowadays, because we are like a tertiary center. We come across patients who are primarily having severe airway dysfunction, recurrent heart failure admission, or I would say something like an advanced heart failure patient. And here definitely I can say that if it is an advanced heart failure, ARNI is a very important molecule, which I would say it should be substituted for ACE inhibitor or ARB. So if the patient is say on ACE inhibitor, ARB, and getting a heart failure, I will like to replace it with the ARNI, which is found to be very useful, both in the immediate setting in a longer run. And here also the purpose is I may start with a low dose and go to the higher dose, gradually titrating to up to 200 milligram 2 times a day. That is the maximum dose which can be given for the ARNI. So that also is a very important thing. So that also we have to keep in mind regarding this. So another important heart failure molecule, I would like to say, it is because of the SGLT2 inhibitor. It has been approved recently. That is empagliflozin and dapagliflozin. Both are approved. It's SGLT2 inhibitor, and it is separate. Okay, so it is not that that patient is on ARNI, we should not be giving SGLT2 inhibitor. SGLT2 inhibitor itself also is a very useful molecule, and it should be added. It is a class 1 indication. US FDA has approved SGLT2 inhibitor for heart failure patient. So there are 2 aspects we have to keep in mind with the SGLT2 inhibitor. Patient, if it is having diabetes, then definitely this is a good molecule, either empagliflozin or dapagliflozin, primarily to prevent the heart failure progression or future development of heart failure. That is one. And second very important thing is patient may not be having diabetes, patient may be having only heart failure. Still also SGLT2 inhibitor is very useful, and it has found to show a significant advantage, primarily because of its mechanism of action, that it causes more of a diuresis or glucose urea along with their fluid, and sodium is a little bit reduced, and that is the reason the recurrent heart failure admission is significantly reduced. So this is also an important molecule which should be there in this patient. Another question is there, I don't know whether we have time or not, but can we treat a patient conservatively if the patient is having no MI1s and just shows RCA LLE 90%, please advise for bypass. Before 4 months, ejection fraction is 40%. Last week now shows 45%. His age is 75. whether it is high risk or not, and medicine should be given cardiovascular. Okay. Now, this is a very important question. Whenever the patient is having, say, LV dysfunction because of ischemia, okay, ischemia may be because of significant coronary blockage, then definitely we have to treat them. We have to correct the ischemia. So in this patient is having say ejection fraction 40 to 45%. It is primarily because of reduced blood supply to the heart. So it's a very important diagnosis, important etiology for a LV dysfunction patient. And if it is there, primarily we have to treat. And definitely risk may be a little bit there because of say age or maybe because of diabetes and little bit of LV dysfunction. But we can control the diabetes in a nicer way. We can have the ejection fraction, heart failure treatment optimized in this patient. And in its good center, if surgery is done, then definitely risk is significantly low. So diabetes, if it is nicely controlled, if we optimize the therapy for heart failure, age is a problem which we cannot change. But otherwise, bypass surgery slightly higher than the routine risk, but it should be offered to the patient because in the long run, the outcome is very good in this subset of patient. So any patient who is having significant coronary disease and having a significant, in having a LV dysfunction, we of course risk may be slightly higher, but a bypass should be done. And because if you don't do bypass in a patient with significant coronary disease, or if you don't relieve the ischemia, it may be because of if it can be corrected because after angioplasty also, but ultimately ischemia needs to be corrected. If ischemia is not corrected, then patient's prognosis is not good, and ultimately patient is going to have heart failure also. And later on, the LV dysfunction may progress, and at that time, risk is going to be much higher than right now. So it is always better to correct the ischemia either by doing angioplasty or a bypass surgery, and definitely there is going to be improvement as far as ischemia is concerned, as far as heart failure is concerned, and patient is going to have a good long-term mortality advantage as well as a good morbidity, or patient is going to have a good a healthy life. That's my recommendation. If we have a time, we can go ahead. One or two question is there. How often do you use? Hello, we have time. So how often do you prefer to use biomarker in management of heart failure and ACS patient? Now, repetition of heart biomarker or use of doing it again in a patient who is having a say heart failure is very important. I do is very frequently in my OPD patient also, or patient is admitted. Suppose the patient is admitted in the hospital and we are having what we can say antiproben, which is very high at the onset when the emergency room patient is there, then definitely I would it's helpful at the time of admission, and I will repeat maybe after 3 or 4 days, or I may repeat at the time of discharge. Now this is very important because there has to be a significant fall in the NT-proBNP level from admission to the level of discharge. So suppose if the fall is not significant or it is slightly gone on the higher side, then definitely it's not going to be very useful. But suppose if it is something like NT-proBNP we are repeating and then significant fall, okay, so suppose NT-proBNP at the time of admission is 15,000, at the time of discharge it has gone down to say about 2,000 or 3,000, definitely we can say that significant optimization of heart failure treatment has been done. Okay, so there is no need of this thing of any worry, because if the NT-proBNP is not fallen down, say less than 30% is the fall, which is the cut point. If it is less than 30% and NT-proBNP at the time of discharge is very high, then patient is not optimized with a good treatment, and there is very high chance that patient may have recurrent heart failure admission. So that is important thing we have to keep in mind. At the same time, on the follow-up also, as in my lecture also I have mentioned, we can motivate the patient. Okay, we can get this patient on the OPD basis also. And if NT-proBNP is rising or NT-proBNP is significantly elevated compared to the previous one, that means there is some destabilization which has occurred, and we really need to optimize the therapy of the heart failure. So that is another important thing we basically have to keep in mind as far as NT-proBNP is concerned. As far as ACS is concerned, troponin repetition, as I have told, in the acute setting is going to be really helpful. Later on, it is not going to be much helpful, because once you have diagnosis, once you have treated the patient, there is practically nothing like repeating the troponin level later on. But we should be repeating troponin in the acute setting when we really want to differentiate rise of troponin, whether it is acute associated with some acute ischemic event, then definitely this troponin repetition is very helpful. So that is an important thing we have to keep in mind. Another important question, another question which has been asked is HS troponin, how much time it takes to rise after myocardial infarction, and what is the cutoff? Very important question. The most important thing, as I have told, I practically do an ECG in this setting. If ECG is showing a significant ST elevation with a prolonged chest pain or a significant chest pain, cardiac chest pain, then definitely straight away we can go for doing intervention. There is practically no need of doing troponin or HS troponin. As far as SS troponin is concerned, in one of the slide also it has been shown that it takes about 2 to 3 hours to rise. Okay, and that is the reason why there are algorithms which are set for troponin levels. So one important thing is, as I have told, ST elevation is there, straight away going for the intervention. If troponin is elevated, patient, let's say, onset of chest pain before 3 hours, ECG is not showing ST elevation, but the troponin is, say, 5 times more than the normal range, then practically we can say that because the troponin level is 5 times more, it is definitely a cardiac element. A patient is having to have bad prognosis, and ischemia should be ruled out. Many times we perform an angiography as early as possible to salvage the myocardium. We don't want a myocardial necrosis to occur, because basically it's a marker of myocardial necrosis. So that we have to keep in mind. Another important thing, cutoff value, as I have told, more than 5 times, definitely we can straight away, it's a myocardial infarction. There is nothing needs to be done. If it is a level is little bit elevated, not up to the 5 times. Important thing in this setting is, as I have told, we can repeat it after 1 hour. Okay, similar to ECG, we are repeating after, say, 1 hour. Many times the first ECG may be normal. Okay, and second ECG, there may be an ST elevation. So normally we repeat the ECG after 1 or 2 hours. Similarly, we can repeat the troponin after 1 and 2 hours. Suppose on the second time it is same level. Okay, it is not gone, or it is, say, in a normal range. Okay, then practically we can say there is very less chance that patient is having acute myocardial infarction. So 1 hour algorithm is there. Another is a 3 hour algorithm is there. These algorithms are primarily set to make the diagnosis of acute myocardial infarction fast, and at the same time, we don't want to miss the patient, okay, of diagnosis of myocardial infarction. So in acute setting, if you want to, say, discharge the patient on first troponin, chest pain onset is, say, 2 hours, and troponin is not much elevated, then, and if you send the patient, sometimes it may happen that patient may have ischemia and troponin level may increase after 2 or 3 hours. And that is the reason these algorithms are set. Both purpose should be maintained, should be kept in mind. One is, we don't want to miss the myocardial infarction, because if there is a necrosis which has started, we have to pick up them early, and definitely we have to start a treatment in the form of, say, low molecular heparin or something like this. Second important thing is, at the same time, if you want to discharge the patient, we need to rule out this. So that means a true troponin level 1.5 hours or 2 hours apart, definitely we can straight away tell that there is no myocardial infarction, and the patient can be sent home. That is the logic of doing or repeating the troponin in acute myocardial infarction. So HS troponin level compared to the regular troponin level increases in the blood much faster, and that is the reason when you want to rule out the myocardial infarction, or you want to say rule in myocardial infarction, then HS troponin is found to be much helpful in this, because it rises much faster, maybe 2 or 3 hours it starts rising, and that is the reason HS troponin is nowadays much more preferred compared to the standard heparin. I think there are no more questions. So thank you all for joining this nice session and interacting with all of you. There are so many nice questions which has been asked during this topic. I personally is taking care of many of our patients with heart failure and acute coronary syndrome. And we all know that heart failure, more and more number of even in your practice is going to be for the heart failure. So keep in mind that heart failure incidents are going to increase. Day by day, you are going to see more and more patients of heart failure, and you should be aware of, like, say, BNP as a marker or troponin as a marker, which is very helpful for diagnosis this condition. At the same time, you should be aware of all the newer molecules for the treatment of heart failure, which has recently been approved. I would say that since last 20 years, there was no molecule which has really found to be beneficial for heart failure treatment. But after ARNI, last 4 or 5 years, and the SGLT2 inhibitor, which is now available and which is approved by US FDA, you should be aware that when it should be used, advantage, side effect, importance of going that to the highest maximum possible dose. These things are all important we have to keep in mind. So thanks all for joining during this program. I also really have enjoyed and hope that you must have got a reasonable answers of your queries which you raised during the discussion. Thank you very much.